Next, we're going to talk about the gastric bypass operation. The gastric bypass operation is what it is. The name of it is also known as Roux-en-Y. And there's a letter Y type of an anastomosis that's created. With the gastric bypass operation, as the name implies, the stomach is bypassed. So far, we've talked about normal anatomy, sleeve gastrectomy, duodenal switch operation, and the adjustable gastric banding. And in every one of those discussions that we've had the food travel down the esophagus into the stomach in all of the cases, one way or the other, even through a narrowing, and then they've gone through the pyloric valve. With the gastric bypass, the food travels down the stomach through an artificially created narrowing and bypasses the stomach and immediately goes into a loop, a segment of the small bowel, and the food travels down the entire length of the small bowel. There's a very little stomach pouch that's left at the top, so you have an abnormal connection between the pouch of the stomach to the small bowel that's created. As the food travels down the length of the small bowel, ordinarily, with normal anatomy, sleeve, duodenal switch, and the adjustable gastric banding, there would have been a series of reactions that would have taken place in the stomach. And those reactions do not take place in the gastric bypass patient because the food never enters the stomach. The stomach is bypassed. The food also never has a chance to go through the pyloric valve because the stomach connecting it to the small bowel is completely bypassed. So unlike the rest of our discussion where the food travels down from the stomach into the small bowel through a regulator of the pyloric valve, with the gastric bypass, it enters in an unregulated format into the small bowel. So you have the food that enters from the stomach pouch into the small bowel in an unregulated format. We have the juices from the liver and the pancreas traveling down through a segment of the small bowel, and they mix with the food through the majority of the length of the small bowel. As the food travels down the length of the small bowel and the juices are mixed coming in, fat, protein, and carbohydrate gets absorbed. Carbohydrate will also get absorbed at the segment of the small bowel that's connected to the esophagus or the stomach pouch before the juices are mixed with it. And the part of the small bowel that carries the biliopancreatic juices, no absorption takes place. The gastric bypass operation has at best 50% excess weight loss, and what that essentially translates is to, if a patient has 100 pounds to lose, then long-term data suggests that anywhere between 50-60% of their excess weight will be lost and maintained. Complications of the gastric bypass is dumping syndrome, solid intolerance, marginal ulcers, and these are essentially technical issues that develop with the gastric bypass. These are not a function of the surgeon, the surgery, laparoscopic open, or anything. These are just the outcome of the gastric bypass with regards to the different complications that happen independent of all of the variables. I'm not a fan of the gastric bypass operation. I think, in my opinion, there are better surgical procedures available out there that will give the same benefit to the patient without really causing a lot of the behavioral or social issues that follows the gastric bypass, such as the dumping syndrome and marginal ulcers and so forth. When it comes to summary of all of the weight loss surgical procedures, all of these data are tabulated on an outcomes data that's available on our website, and I'll recommend every patient who's contemplating any weight loss surgery take this information, go for multiple opinions, go to surgeons that have done multiple procedures, review the data, and only make the decision that'll provide the most sustained weight loss long term.